Now for a demonstration of open chest tube insertion. We're going to assume that the patient's already been prepped and draped. So we have all of our equipment ready on our tray in front of us. I'll have an assistant actually hand me a chest tube. Perfect. Thank you. So I'm going to remove the trocar. And then I'm going to actually get the chest tube ready for insertion. And I'm going to make sure I clamp the end as well. Landmarks are similar to the closed technique. So fifth intercostal space, either anterior or mid-axillary line, corresponds to the nipple line in a man or the inframammary crease in a woman. So again, after landmarking, I'm going to put in local anesthetic. So I like to actually go right to the rib, draw back, inject, and then move slightly cephalad, aspirating before injecting. In the case of an open chest tube, I do like to use a significant amount of freezing as this is a painful procedure. Once the local anesthetic has been infiltrated, what I'm going to do is make an incision along the rib. The key is to make an incision long enough that will allow you to insert the chest tube and snap. You need to make the incision large enough to insert both your finger and the chest tube. After the incision's made, what you're going to do is to take a snap and insert it into the incision that you've just made. The idea is, using force, you're going to find the rib and then go cephalad to the rib, pushing in until you feel a pop in the thoracic cavity. Once you've had that done, you're going to spread the snap to make a hole big enough to insert both your finger and the chest tube. Once the snap is still in the hole, you're going to slide your finger over the snap into the hole in the chest wall. Next up, you're going to take your chest tube and insert it. In the case of a simple pneumothorax, you want to try and angle the chest tube anteriorly or superiorly. In the case of an effusion, you're going to want to aim it posteriorly. You're going to slide the chest tube beside your finger, taking care in the situation of trauma not to cut yourself on any broken ribs. Once the chest tube is in the thoracic cavity, you can actually remove the chest tube clamp. And then you can secure the chest tube. I like to leave the ends of the suture quite long when I'm initially tying in the chest tube, so that you can use both ends of the suture to wrap around the chest tube. This will allow a more secure attachment. Once the chest tube is in, I have to take the two long ends of the suture and wrap them around the chest tube in opposite directions. This way, the tube is attached both to the skin and the tube. I would then finish closing the rest of the wound from the incision. I'll then place a dressing on the chest tube. Which will then be attached to the skin with tape at a later moment. I will then have an assistant come and attach the drainage to the chest tube. After which I will unclamp the chest tube. This way, if there is any blood or fluid, it will remain within the closed drainage system. Once the chest tube is attached to the drainage system, we need to secure it so that it stays in place.